Hello, my name is Eric Duke. I started my orthopedic technologist career in 1991 in the U.S. Navy. I served about 8 years in the Navy. I then went to a large company here in California where I've been working there about 24 years. I also currently instruct at the Grossmont College for the last 6 years. So I have about 30 years of experience. And during that time, what I really learned throughout from programs I've been to, classroom, at my work, you can always take tips and tricks and techniques from other students or technicians you work with. And so what I want to share with you today is things I've learned over the last 30 years with specific casts, the Cobra cast. But secondarily, about 3 years ago at my facility, we switched from doing outrigger cast to Cobra cast. During that time, several of us that got used to doing outrigger casts started to learn how to do Cobras, and we had to come with some techniques that work best for us, the patient, and the application of the cast. And what I'm going to show you today is what I think is the best rendition of what I can put on that Cobra cast. I think this will really help you in your practice moving forward to apply this cast the best way you can. So let's get started. When I say Cobra outrigger cast, what I'm saying is a ulnar gutter cast, radial gutter cast, whatever you may call it or your provider calls it. We call it a Cobra cast in my facility, but that basically means a cast that includes 3, 4, 5, 4, 5, or whatever finger that is injured or metacarpal that's injured. But I want to start with what materials we're going to need for this procedure. We need a few things to be prepared. And so what I ask my students to do is always be prepared for what you might need. And so what I have here in front of me is what we would need for any of these kind of casts. You start with 2-inch stockinette, at least 2-inch stockinette, most commonly. Sometimes you might need a 3-inch stockinette for a larger arm, but 2-inch usually seems to work the best for me. If you have it, 1-inch stockinette for around the thumb. Follow that by padding, web roll, or any padding you might want to use, but 2-inch use seems to work the best. About 1 to maybe 1.5 rolls of that. That'll be followed by fiberglass, 2 rolls of fiberglass. 2-inch usually works pretty well. Maybe a 3 and a 2 based on your patient size and need. Clearly you'll need gloves. You roll your fiberglass, some scissors. And then at the very end of the cast, which I'm going to show you, it's a pretty big technique, is using a liner that really works really well to pad between the different fingers near the cast. That seems to really help out with the patient's comfort and fitting of the cast. So let's get started with the cast. When you're applying the Cobra cast, not always, but a lot of times this cast is applied before a boxer's fracture. So there is some concern about that, or just kind of techniques I can share with you when I'm doing that. So the hard part about this cast is when you're trying to put the cast on and put the mold on, you only have a certain amount of time with this fiberglass. So you want to make sure that you use that time wisely. But remember, as you're putting the cast on, when you get your first layer on, you need to get that mold in. And so remember, the mold's going to be at the metacarpal head. What fools you a lot of times is when you bend the fingers down, the metacarpal head is really right at the distal palmar crease. So one of your fingers, your thumb, or has to be right here at the metacarpal head. The second one will be below it, proximal to it, on this side here. So the hard part about it, you can imagine this, if you're trying to take the fingers, hold them down, and mold it. That's basically how I do it. I grab my hand around the cast, like so. I take my finger, I push against the metacarpal head, and then I use this thumb to push back to give counter pressure. That's how I do my mold, just like that. I push and hold. Again, this is with the block or however the patient's being anesthetized for the treatment, but that's how I do my mold, just like that. Lastly, I want to talk to you about is sometimes what I'll do if I know I have to do a mold, I may fan fold the material, just one layer here, a little extra material right in this area here to have that mold hold. But minus that, putting the cast on like I showed you in the video coming up, that's how you're going to do it. That's where you put your mold if you need to do a mold. Again, that's for a boxer's fracture. All right, guys, so we're going to do a Cobra cast here. When I use the word Cobra, I mean either radial gutter or ulnar gutter cast, but it's a cast that includes the arm and a certain amount of fingers. It could be 4 or 5, 3, 4 or 5, but again, that's based on the injury the patient may have. So let's talk about parameters first. Again, the parameters of the cast approximately are going to be about 2 fingers below or distal to the antecubital fossa. Remember, that can change based on the way you put the cast on. So you got to be very careful when you put the cast on that you don't bend the arm up and then measure, because then you're not going to be 2 fingers any longer. That's a typical problem people have with this cast, or any kind of cast, short-arm cast. That being said, we're going to come down to the hand itself. Again, whatever fingers that are going to be injured or the provider wants you to apply to put in the cast, you're going to put those fingers in there. It could be 4 or 5, 3, 4 or 5, like I said before. You can do all 4 sometimes as well. On the palmar side, at the distal end, again, you want to follow the distal palmar crease for any finger that's out of the cast. That way it can move freely. And we should have free range of the thumb so it can move normally as well. The way the arm should be positioned in the cast, wrist should be about 15 degrees of wrist extension. There should not be any radial deviation or ulnar deviation, so the wrist should be about neutral. Forearm neutral. It should not be overly supinated or pronated. We do want to pronate a little bit because we know the ulnar stylo gets a little larger or more prominent in a little bit of pronation. So if anything, you want to be neutral or a little pronated. You never want to be supinated when you put this cast on. So wrist and about 15 degrees of extension. Arm or forearm either neutral or a little bit of pronation. And if you can, whatever fingers should be in the cast, bent down a little bit. Again, I find sometimes when you try to force this or have the patient force this, they'll want to straighten their wrist out, and then you'll have a hard time getting, we call it extrinsic plus. What extrinsic plus is, wrist at 15 degrees, MPs at 90. That's the goal of the cast when you're all done. PIP and DIP aren't generally, most people, the injuries are not in the phalange itself. It doesn't really make a difference where those are flexed or extended, but more the MP and the wrist extension seem to be the biggest issue. That all being said, this cast is put on because you usually have a boxer's fracture or some kind of metacarpal fracture. It could be an injury in the phalange itself, one of the fingers. That's why sometimes you have to put multiple fingers in the cast. But that being, with all that, you got to know what you're treating clearly. But we're going to put the cast on. So I'm going to do a cast with a wrist in the cast with the fourth and fifth fingers in the cast. I'll start with putting some padding. It could be stock, it could be web roll, it could be gauze, but you want to put something between the fingers to prevent maceration. It's really important. So I'm going to put some, I use cotton because it's already here. It's easier to use. I'm then going to grab a piece of stockinette, 2-inch, that's going to be longer than the fingers themselves, to allow for padding for the fingers. So I'm going to start with that. Then I'm going to cut a slice in this, or a cut on one side, not both. So that slice here will go over the fingers. The cut part will go between the third and fourth phalange. Next, I'm going to move my 1-inch stockinette. I'm going to cut a piece of this off. Like the first stockinette, I'm going to cut one edge of it, about 2 inches or so, maybe 1.5 inches. That'll go on the thumb. Take the cut piece, it'll go towards the web space between the first and second metacarpal. So these two pieces of stockinette now. The third piece is a little bit harder. This is the one you have to really think about a little bit. This is your stockinette for the arm. With this, you're going to need two cuts. You're going to need one for the thumb and one between the third and fourth metacarpals. So basically, I want to make sure it's a little longer than I want it. That's how I measure it first. I make my cut for the thumb first. I want it to be a little bit smaller. I don't want it to be too big because I want it to make sure it fits around the thumb fairly snugly. Once I do that, on the opposite side of the stockinette, make a little larger cut, a little higher, or a little more distal, because your metacarpals are more distal than your thumb. So you kind of think about that, what that distance is in your head. It doesn't be exact, but it should be close. About a third of the way across the cut you want to put here, something like that. Now I'm going to take the stockinette. I'm going to apply it to the arm. Again, the wider cut's going to go. The second and third fingers will be inside the stockinette. Bring the thumb down, the hole for the thumb. I'm going to go back up here and make sure I don't have any wrinkles, or less wrinkles, I should say. On the thumb. Double check my wrist, make sure it's not ulnar or radial deviated. Make sure my stockinette's far enough down so I get the cast down approximately as far as I need to. Now I'm ready to put my cast on. Now I do talk to the patient prior to the cast being applied about a few things. I find if I tell the patient prior to the cast being applied that it's going to be really, really warm and it's going to feel fairly snug, they tend to accept it a lot better if I do not tell them that. So I always tell the patient as I'm applying the cast, it's going to feel very, very warm for about 10 to 15 minutes while the cast material hardens. And it'll probably feel snug for about a day, day and a half. That's pretty normal for a cast. But again, if I tell the patient prior to the cast being applied, they tend to tolerate it a lot better than doing it as it starts to get warmer, as it gets tight. So let's get started. So we've talked about how the arm's going to be positioned, what we're kind of looking for. We get ready to apply the cast. Now you might see some fuel holes in here in the stockinette. That's okay. We're going to cover that with our padding, so don't get too worried about that. As you see at the very end, when we roll these things back, a lot of these things you're seeing here will be covered with the material we're going to use next. So again, I'm going to use some web roll. I use 2-inch. That's my preferable thing. If you have someone with a really large arm, you might use a 3-inch, but 2-inch seems to work pretty well for me. So I'm going to start with my web roll. You're going to start at the wrist like you normally would with a short arm cast. Come around. Between the thumb or the web space of the first and second metacarpal. Back down, through one more time. As I do this, I'm starting to angle up. I'm going to roll the hand this way just a little bit. I'm going to angle up towards the metacarpal heads, kind of like this. If I'm too far down, I'm going to create wrinkles, so I want to kind of aim upwards like this. I come to here, I'm going to palm up real quick. I'm going to tear the material. I'm going to put my hand, I'm going to tear the material so that I can pass between the second and third metacarpals. Sorry, third and fourth metacarpals. I'm going to slide it through here. Kind of palm it away one more time. I'm going to continue to do this all the way up the finger. If you're not sure, and your provider may be different than ours, but my provider generally will cover the entire phalange or the finger, all the way past the tip, to ensure that I've covered every injury that could be in that finger, or fingers, no matter what you're trying to treat here. I'll come back down after I've done my 2 layers, similar tear between the metacarpals, and back down to the hand. The web space, I'm going to tear it there. I find that I need to reposition the patient a few times during this procedure. They're going to want to wander. They're in pain generally. Remember this, they're in pain. Back down the arm, 50-50, normal 50% padding, all the way down. Grab a next roll, 3 to 4 layers at your proximal in like normal, get normal padding. That's enough. Ulnar style, I would pad that a little better. If you have ladies or people who are much more skinny, they're going to have a problem with this area here. So getting their arm a little bit of pronation and really padding this area here will really help with that pain. If they do not do that, they're going to have a lot of pain on pronation. A little padding between the web space of the thumb, the second metacarpal. Again, last check, Wrist extended a little bit, fingers down just a little bit. They may not be able to do much of that. No radial deviation, no ulnar deviation. We're ready to apply the cast now. So I'm gonna start with my gloves. And start my material. I'm starting with one roll of 2-inch fiberglass. Remember, it's always going to be room temperature or cold water, never hot water. Like the web roll, I'm going to start the exact same spot with the web roll. All fiberglass, you push it on, you never pull it, come up. Now start your cuts with your scissors. So you're going to take your hand, bring the scissors right to where you want to cut. It's pretty simple. Don't think about it too much, put it where you want it. Now you come back down through the web space or the second and first metacarpal, back up. I'm gonna come right to the first area here between your third and fourth metacarpals. If you can see that there, we're gonna cut across. It's called like a J cut. Hold it right here so you can control where it's gonna go. Come down and through. Roll it over, like so. Repeat this process up the phalange as long as you need. Maybe one more cut. The rest can be probably full 2-inch layers. Get about 2 or 3 layers across here. Come back down to between your fingers. Roll it over. Do one more pass between the web space of the thumb and the second metacarpal. And now you're at the hand, or the arm, I should say. 50-50, your proximal, you want to roll 3 or 4 layers, then come back up the arm. Now here's the part where I think it really helps with the professionalism, but the fitting of the cast. So clearly we're going to roll this back like we normally do. Make sure we roll it back, we get a nice little edge of padding there at the proximal end. I'm going to kind of show you the palm here from the above camera. Okay, so we come to the thumb now. We're going to wrap this down in the thumb. Make sure we get a nice fit around the thumb. Some of you might need to trim this a little bit. It's still too tight. This patient has a bigger hand than some, so a little bit of trim there for it. This is where I really think this extra piece of stockinette helps out right here. The area right here always seemed to be a problem when I first applied these casts. I could never figure out a way to cover these professionally or make it real comfortable for the patient. So I found this technique really helps out here. So what we're going to do is I'm going to roll this back here. I'm going to roll it over this area and then back this way. What you're going to find is, one, it looks more professional, but secondarily, it's going to fit more comfortably right in this area here for the patient. Make sure you don't get too many wrinkles between the fingers here. I'm going to have to cut over here just a little bit. Now my positioning comes in. So again, I want the wrist back about 15 degrees of extension. And what I have to do at this point, I'm going to palm this in here. I did take one of my fingers, usually I take my thumb, I press against the metacarpal heads and I start to flex the MC down, or the metacarpal down. So we get that 90 degrees. I want to maintain the wrist extension that I had, but I also want to get these fingers flexed down. And so what I literally do is I take my thumb and I press against the metacarpal head, then I take my other hand and I bring the fingers down to ensure that intrinsic plus position is going to be achieved. Now I hold this. I can only do one roll at a time because this positioning is very important to get, but it's hard to do if you wait to do the second roll. The material will generally harden up too quickly. Secondarily, if you were going to put a mold on, which I'll show at the very end of this video where you put a mold, you need to do a mold right now as well, because a lot of times you can put both rolls on and do all this stuff, but with this cast I really find it's very difficult to put both rolls on and get position that's going to be appropriate. So I take a little more time, but sometimes more time is okay, to get the cast fitting properly. So once this is hardened, which is pretty close right now, I'm going to clean up my materials here a little bit and make it a little prettier, because I think aesthetics do make a difference. I think when you have a cast that's placed that looks more professional, the patient do respond to that and feel more comfortable with the treatment they're getting. Trim up my extra stockinette. Perfect. Now I'm going to put my second roll of material on there. I start at the proximal end because I want more material by the hand. Start up here, roll distally. Hand this way, same cut between the thumb and the index finger. Back to between the third and fourth metacarpals. Make sure you're connecting all your stockinette. So you're pulling all the stockinette down so you're controlling the edges of the stockinette. Cut through here again. Angle more down towards the hand itself with the palm. Thumb and index finger. Catch all your edges. Finish off your roll. Dumb things like putting the edge down here are really helpful because it's not in the way. It's not up here where I rub the patient's arm, and it seems to be a lot better down here. Now I'm gonna rub the cast. I'm gonna do my molds. Again, you're gonna do an interosseous mold. So interosseous mold is gonna be on the forearm, not on the styloid. So just proximal to the styloid. Styloid's here. A couple molds there to make sure you flatten the cast out a little bit. I'm gonna go to the palm. So my fat pad of my hand here on the back of the hand. My thenar eminence and my thumb will go against the palm of the hand. I'm going to squeeze the palm itself to flatten the cast out. And then I'm going to immobilize the metacarpal head again. I'm going to bring this back down again to get that intrinsic plus position we're looking for. Now I'm going to hold it until it hardens. It may take 2 or 3 minutes. Once that's hardened, we'll go to the next part, which is padding the cast between the third and fourth metacarpals or phalanges and around the thumb, which is really important, I think. Now we're going to move to padding. That's all my material here. So what we had to use is a material called soft liner. This is synthetic material, but it basically has adhesive backing to it. So you're gonna cut a couple pieces out this. What I generally do is I cut 2 thinner pieces, probably about a 1/4 inch, maybe 1/2 inch wide. The total width of it. 2 pieces like that one, like that I should say. One a little bit longer, probably about 2 to 3 inches wide, like so. So here's my 3 pieces. The first one, you're going to take the backing off. I like to pad right near the thumb comes near the cast. As the thumb comes down into the key pinch position and or the opposition position, it tends to get rubbed by the cast quite a bit. That just pre-pads it so the patient won't have any rubbing or irritation. Now I make my attraction where I spend my time between the third and fourth metacarpals or phalanges. The small piece will be used first. You can tear the backing off. I'm going to take it, I'm going to kind of shift it back down here, right to the base, very base of it, and kind of angle it down each side. Same idea of the thumb, it pads there here, But now I have this area here I need to pad as well. A larger piece would take care of that. Padding, the backing removed, and then we'll come all the way down by the base again and pat it. Made this one a little too long. You can trim it. I can't add, but I can take away. So now, if you can see here, the patient has complete padding between the third and fourth metacarpals. This is a big problem with this cast. One area here becomes very kind of ratty or pokey, and then this area here becomes very uncomfortable as well. So I think this technique here of rolling the stockinette back and utilizing the soft liner really seems to help with the patient's comfort in the cast. And once that's done, the patient, I give the patient usually some soft liner to take with them because it does get dirty. It's white. It may get dirty. It may get may fall apart. So you may need to add more at some time, or maybe double it up in the future. But minus that, I give the patient instructions of, again, don't get the cast wet. Don't place anything in the cast. Don't try to scratch. When I keep it wet, I have to explain it to the patient. Remember, patients may not have had a cast on before. So it's a bag over the cast, arm up in the air. So think about the water hitting the hand and rolling towards your armpit. So using the shower curtain rod, top of their head or something, but putting a bag over the cast, arm up in the air seems to work the best. Not putting down the cast. Why are they going to put something down in the cast? Because it itches. It's itchy. Well, moisture is what's causing itching. Some from sweat or from showers, moisture. So they take really hot showers, maybe a bag over the towel over the cast first in a bag. If they're going to work out, try not to work out as much, or try not to do things that make them sweat so much. If it does get wet inside from sweat, they can take a blow dryer on the cold setting only. They can blow dry the cast and get cool air down there. It helps dry out the skin. But again, we don't want them to place things in the cast to try to scratch their skin. That'd be not good for their skin. And then lastly, just keep it clean, keep it dry, and be careful with their hand and their cast. All right, just talk about cutting the cast off. So there's some questions about how to cut this cast off. Some people will cut it just dorsally and volarly. I find just to cut it radially and ulnarly, and that way you can include the fingers. So sometimes if you just cut it on this side and this side, what happens is the fingers are still entrapped in the cast. It becomes kind of uncomfortable for the patient. So I find it just be easier this way. So again, use my cast saw. Typical cast saw techniques that you should be using generally, but just ensure that using it properly. And then just remove your cast like you normally do. Just be careful around the fingers where you're cutting the cast off. The patients will probably be sore and stiff, and that's where their fracture is as well. So just pay more attention to the hand where the fracture may be.